Okay, so good afternoon. Since we have a tough moderator, so I will try to to be concise and quick. I wish to thank the organizers, Professor Yossi Klausner, for inviting me to give this tough talk. I couldn't say no to him. He was a little bit annoying, but I learned to know his qualities. So thank you. Today we are going to speak about something that we are speaking about it for the in the last 2 decades, evidence-based medicine, and how does it affect our practice. How do we advance with the this one? Okay. So I am proud to announce no disclosures, and you will see why. Okay. We're going to speak about evidence-based medicine. What is evidence-based medicine? Evolution of surgery as a science. Do we really need evidence-based medicine? Is the current evidence-based medicine, or EBM, I will call it EBM, okay, good enough? And what do we need to do in order to improve the current EBM? A quick search in the literature, when you type evidence-based medicine in the midline, revealed something, a huge number of articles dealing with it, something like 135,000 papers dealing with evidence-based medicine, a huge influx of papers dealing with it. The birth of evidence-based medicine actually was a necessity, because since the World War II, there was a rapid development of biomedicine, and was a huge influx of medical knowledge, and the basic theoretical knowledge was supposed to be combined with the expert experience. So there was a need for scientific data with much stronger, we call it epistemological basis. Epistemology is the science of knowledge. Archie Cochrane actually was, he should be given the credit of starting the whole thing of evidence-based practice, evidence-based medicine. Already in the 1970s, he started to criticize the British medical system because he was thinking that we should bring together the results of relevant randomized trials in order to improve our practice. The evidence-based medicine actually, evidence-based practice is an interdisciplinary approach to clinical practice that has been gaining ground following its formal introduction in 1992. He, together with David Sackett, founded this movement, which is called EBM. So it started in medicine, and it spread to other fields of other practices. Tradition, personal experience, anecdotes actually were replaced by evidence from high-quality studies. This was the whole idea behind the evidence-based medicine. So David Sackett and Archie Cochrane were developing it in McMaster University as a new way of teaching, learning, and practicing medicine in 1992. And David Sackett defined it as the integration of best research evidence with clinical expertise and patient values. So it's not just a question of the highest level of research available. It should be combined with clinical expertise and patient values. So EBM is an approach to medical practice. And the main purpose of it is to optimize decision-making by emphasizing the use of evidence from well-designed and well-conducted research. And although all medicine based on science has had some degree of empirical support, the EBM goes further, and it classifies evidence by its epistemological strength. So it requires that only the strongest types coming from meta-analysis, systemic reviews, and randomized control trials can yield strong recommendations, and weaker types, such as case control studies, case reports, and so on, can yield only weak recommendations. So it's somewhere between truths and beliefs, the knowledge. And this movement was gaining momentum, and they created a center, actually, for evidence-based medicine, which is situated in the Oxford University. This center was founded by David Sackett in 1995. I will make a quick review just to remind you what are the levels of evidence according to the Oxford Center for Evidence-Based Medicine. There is level 1 evidence, which is divided into ABC, level 2 ABC. The strongest is the systemic reviews of RCTs, then individual RCT with narrow confidence interval, all or none studies. The level 2 is the systematic reviews of cohort studies, 2B individual cohort study, including low quality RCT, and 2C, these are the outcome research of ecological studies, 3 and 4 and 5, 3A systematic reviews of case control studies, 3B individual case control study, 4 case series and poor quality cohort and case control studies, and 5 expert opinion. Okay, so this is the lowest lowest strength of evidence-based. It's the pyramid starts from editorial expert opinion, and systematic reviews of RCTs is the highest quality. And according to it, there is grades of recommendation, A, B, C, D, where A is consistent level 1 studies, and D is the level 5 evidence or troublingly inconsistent or inconclusive study of any level. Okay, so how does it work? Step 1, we should first of all identify clinical information needed. Step 2, we should formulate an answerable question, which is not that easy. Okay, it's a skill to be learned. The next step is to track down the best evidence, the highest quality evidence. Step 4 is to critically appraise and criticize the literature, okay, to evaluate quality and to test the relevance and applicability of the literature. Step 5, to apply this only if it's appropriate to our patients, and to study the clinical benefits, side effects, patient wishes, and perception, and the cost issue, of course. So we should ask a good question. A good question should be focused and relevant. It provides clear communication, clarifies our goals and need. It will reduce the amount of time needed to obtain the answer. So it's a skill to be learned. So EBM quickly became a strong intellectual community committed to making clinical practice more scientific and empirically grounded. And actually, we achieved by it a safer medicine, more consistent, and most cost-effective care. So what is surgery, actually? Is it art? I call it apprentice. Apprentice in Hebrew is shuliyah. Okay? Because surgery until the 80s, okay, we were following our teachers, following the chairman of the department. We learned everything from him. Okay? There was not much science in it. Is it science or is it both? Is it science and religion? When we say religion here, we mean personal experience and beliefs, or is it both? Surgery perhaps is an art for good technicians, because good technicians are really have many sides of it's an art, okay? And is it a science for academic surgeons, or should we combine it both? If the far history of surgery, I took it from a book called Aphorism and Quotations for the Surgeon, written by Moshe Schein. It's said by Hippocrates, who wishes to be a surgeon should go to war. That's how surgeons were perceived at older times. I just want to remind you about our history in the Middle Ages and in the, even in the Renaissance period. We were a society of barbers and surgeons. Okay? There was not that science in it. Okay? We were in the same guild as barbers. I'm sorry. Just a small clip
how are you feeling?
of how did surgery look
Yes, of course.
at
There's
these
no
days.
reason to feel afeard. Sheridan here holds the record time for chopping legs off.
18.5 seconds.
You won't feel a thing, pain aside. Nurse, more gin, please.
And for me, please. Thank you. Now, pay attention, students of anatomy. My hands are rather cold, I do apologize. 3, 2, 1.
Okay, I'll stop it. This is the kind of surgery that was done in the Middle Ages, even in the Renaissance. There's not much science in it. Surgery developed beyond the Barbers and Surgeons Society of Surgeons, and it developed in the last century, in the 20th century. These were part, at least, of the figures that created modern surgery and started to create some science in surgery. It takes, ladies and gentlemen, for mastery in surgery, it takes a lifetime. For proficiency, quickly. And human expertise take a lot of time. It takes more than 10 years. Okay, so we shouldn't take surgical expertise as something that we shouldn't take it into account. So is it art or science or both? As I say to you, science and art, more science than an art. I believe that it should be both, okay, because humankind is both art and science. We cannot divide between these two things. So many achievements were made by the evidence-based surgery movements. It established the Cochrane collaboration to summarize evidence from clinical trials. It setting methodological and publication standards for research, building national and international infrastructure for developing and updating clinical practice guidelines, developed resources and courses for teaching critical appraisal. And there are many examples of setting guidelines that reduces morbidity and mortality. There are many, okay, in medicine, in health, there is in asthma, in surgery, antibiotic prophylaxis in surgery, VT prophylaxis, and many more. But are there difficulties, limitations, obstacles, problems in evidence-based surgery? Of course. Okay. The size of medical knowledge. We have heard the previous speakers. It's a very difficult to manage the current knowledge. It's a huge, okay, shortage of coherent, consistent scientific evidence. The quality of our evidence is not that good. Lack of tools to differentiate high-quality research, good from bad. Okay. It promotes a cookbook approach to medicine. Guidelines are not guidelines. Okay? The need to develop new skills, how to appraise literature. No one gave us the tools to do that. Limited time and resources. Okay? About the size of medical knowledge, it's huge. The National Library for Medicine has the huge number of concepts, a huge number of diseases. I don't want to get into the details. One disease per day for 30 years in order to learn all the illnesses. Okay, look how many publications are released every day. 5,000 per day. 5,000 biomedical. 2,000 added to the midline each day. Okay, so how come we can manage all this influx, a huge influx of evidence? Clinical evidence is increasing so rapidly, so we need better skills to keep up to date more efficiently than previous generations of clinicians. Look at the number of publications published since 1950 to 2010. Okay, So we need better ways to manage this, if at all we can manage this. This study from the BMJ, it took 607 reviewers. They inserted 14 deliberate errors in 10 papers. Okay? 9 major errors, 5 minor errors. And the detection rate was just 3 of 9 major errors. Okay? So there should be some responsibility for editors to do that. Editors should not assume that reviewers will detect most major errors, particularly those concerned with the context of study. Okay? And they proved that short training packages have only a slight impact on improving error detection. So no one also gave the reviewers the tools to better review the studies. So the disadvantages of EBM, there are many ethical concerns. It may not be possible for all kinds of questions that we have in mind. Intervention studies screen out problematic subjects such as very young, elderly, pregnant, lacking women, and so on. So these are, I think there's some disorder in the slides, I'm sorry. These are the disadvantages of the randomized control trials. An average randomized control trials take, in the pharmaceutical industry, it costs something like 12 million US dollars and years to conduct. And there are a lot of conflict of interests. What about סליחה, איך אני יכול לחזור לשקופיות? יש פה... איך אני יכול לחזור לשקופיות? טוב, עזוב. בסדר, אני אסדר. אני לא יודע איך זה קרה. Okay. So my point is that our current evidence is not that convincing. It has many flaws. Okay, there are many conflict of interests in meta-analysis of trials. For example, this pharmacological in pharmacological industry, this is a study looking into 29 meta-analysis, including 509 RCTs, and look. More than 2/3 are industry funded, okay? And only 100, just less than half of them reported some conflict of interest, okay? And just 2/3 that reported author financial disclosures had one or more authors with pharmaceutical industry financial ties. Only 7% reported RCT funding source, the funding source itself, and none reported the author ties himself. Okay. Another study, 159 studies from 12 medical specialties. They studied the outcome, extent to which overall results favored the experimental intervention by the funding source. Okay, and see that the stronger the conclusion in the funded trials. Okay. So there is a strong association between funding and conclusion in randomized controlled trials. Another study looking into it and see that the trials funded by for-profit organizations may be more positive due to biased interpretation of trial results. This is from our surgical discipline, industry bias, randomized controlled trials in general and abdominal surgery. Eventually, they took 115 industry-funded trials, and they compared it with 50 non-funded trials. You see that the p-values in the funded trials, okay, they are much more prevalent. They are much common p-values and stronger p-values in the funded trials compared to non-funded trials. So industry is a key player in medicine, there is no doubt. Okay. Another study, just give me 2 minutes, it's very important. Another study, a recent study, which is was published just now, May this year. It revealed that almost half of the physicians in the United States were reported to have a total of 2.4 billion in industry-related payments. And it was higher, there were more surgeons than in primary care specialties and more in male to female. So 1 in 2 are funded, okay? The publication bias, more, if have strong results, it will be published. Negative results, it won't be published. Look at the p-value of less than 0.05, the magical number, okay? More than 95% of clinical results claim significant results. Is it really the reality? And what about the p-value of 0.05? Is it strong enough? Is it good enough? It's not, because there are many questions that we should ask beyond the 0.05 values. There are many studies looking into it with the, and I will skip it because we have no time, but I have to, so the medical literature in many cases leave us confused and disoriented and with unclear results. I just want to give some, 2 examples of, in surgery of how things could happen even without the support of evidence-based medicine. One example is minimally invasive surgery. Do we need always high level of evidence? Look at laparoscopy. Laparoscopy witnessed revolution during the early 90s. And laparoscopic cholecystectomy was rapidly adopted within 2 years, okay, without even one randomized controlled trial. So, and the role of industry here was minimum, okay? So the results, because they were so striking that it was considered not ethical to conduct an RCT. The robotic surgery, again, it's an expensive promoted technology without robust evidence, okay? Why? Because of these reasons. The advantage really is marginal at best, but it allows hospitals to introduce themselves as cutting-edge technology, and it's good for marketing, for competition, although it has also some advantages. And finally, in order to get things more complicated, sometimes evidence do exist, but do surgeons change their practice accordingly? Not necessarily. The example, use of drains in abdominal surgery. In spite of lack of evidence supporting the routine use in the majority of abdominal procedure, most surgeons still use them, okay? Reasons beyond. So evidence-based medicine is a movement in a certain crisis. We need to improve it. Take-home messages, and I will finish, I promise. Surgery will continue to be an art and science, my colleagues, okay? We do need EBM. It saved lives and improved the practice of medicine, but we need better EBM with better tools and cleaner evidence. Current EBM is not flawless. It needs to be more pragmatic, revised, and improved. We need to better incorporate EBM teaching in medical schools and residency programs. We don't do that. No one taught us how to clinically, how to critically appraise an article, okay? We have to produce our own usable, robust, and high-quality evidence, I mean randomized controlled trial, okay? Publisher must raise the bar, their role. Okay, so because you have rule in this, they should raise the bar of the quality of publications published. Okay, research must transcend conflict of interests and minimize industry involvements. Independent funding of national and international bodies for medical research is crucial, because as long as we are funded by the industry, no clean evidence will be obtained. I think it's true here. A 21st century clinician who cannot critically read a study is unprepared as one who cannot take a blood pressure or examine the cardiovascular system. And take a look at this caricature, okay? Would you like a doctor who offers evidence-based medicine, holistic medicine, or personalized medicine? I'll take one who does house calls and one who knows how to examine patients and operate on patients. Thank you very much.
So I will also talk about some thoughts about evidence-based medicine. And my disclosure is that I don't hate surgical science, and I come from a family of scientists, and I'm in the game with publications. I read and write. I also judge papers. But still, there are some problems that we all know about, and I want to focus on some of them. We have to know what is evidence-based medicine, and I won't repeat what has been explained right now, but basically we want to make our practice scientific and apply scientific methods in what we do. And for that we need the building block of evidence-based medicine, which is evidence. Evidence is the product of data and analysis and interpretation, and at each stage we can make a lot of mistakes which will eventually end as a mistake in our conclusion. We all know that evidence-based medicine can be called by names, so we call it eminence-based medicine, and emotional or economical-based medicine. There are many word games like that, but most of them come from appreciation that something is really wrong in this system and we can do better. Why do we need evidence-based medicine? Because if we compare science to religion, there are some similarities. We use basic assumptions, and we have a wide base of literature to rely on, and we interpret our data. But the similarity ends because in science we have skepticism. We don't accept the facts. We continue to be skeptics, and we continue to search, and that's why science is dynamic and religion is static. And this is what we want to avoid. So we don't have any holy cows in surgery or in medicine, because we continue to change all the time. And evidence-based medicine helps us because science can fight all these mistakes that are being done by beliefs or by myth or by chance or by looking at association and getting to wrong conclusions. And we have illusions that what we do really helps, but sometimes it's just an illusion. So basically science is good. So what is the problem? The problem is that we have to be skeptic also about science itself, because we see around that something is not really working as the way we should. First of all, most of the times when we use evidence-based medicine, use it in very simplistic terms, very shallow use of it. So we all know these morning meetings that we fight each other and everybody gets his phone and Google some articles and get the abstract and get the conclusion of the abstract and last word, and then he shows that he is right, and then the other person can do the same and get other results. So this is very shallow use of evidence-based medicine. This is not how we used to how we want to base our practice on. But the most important problem is that we get from the same methods, we get many contradicting results. So we can, for example, argue about what is the best way to anastomose the stomach to the small bowel. Do we do a Bilro 2 anastomosis? Do we do a Roux-en-Y? And there's a surgical, what we call surgical ping pong. Sometimes we switch our practice based on some articles, then we switch back to the previous method. Use the same similar scientific methods, but we get different results. And we have fashion, and this fashion many times is supported by studies, but then this fashion changes and we have other studies to support the new fashion. Let's take for a few examples. For example, bariatrics. We see many procedures that are coming and going. Every one of them is supported by studies. There's a lot of studies about bariatric surgery, but still we don't have an answer which is better. Or bowel preparation. We have many good studies, some of them come from our group, that show that bowel preparation before surgery is not really necessary, it's not really good. But this holy cow is not really dead now because it goes on, and now one of our residents present a conflicting conclusion. Maybe for IBD patient, bowel preparation is still necessary. So maybe what we did before is not really good for all the groups or subgroups of patients that we treat. Something is wrong with our conclusion. Let's, for example, take another example of PSA screening. It came from science. PSA is scientific. It can detect early prostatic cancer. But now if we look at what we do, we see that if we screen 1,000 patients, we save life of only 1 or 2. Along the way, we harm about 60 patients with impotence or incontinence. So this is not so good anymore, even though it was supported by scientific studies. Or mammography screening. Let's look at the magnitude of reduction of mortality. If we take 10,000 people, 10,000 patients screened, not patients, but healthy women, the benefit in terms of mortality is with or without screening is only about 4 patients. So we have a lot of support for mammography screening, but eventually we can find studies that show the opposite. So where are the problems located along the way of creating or getting the evidence? First of all, we have to define whether we should choose to study at all. Not everything should be studied. Then we should look at the methodology and the quality of methodology, like Ahmed mentioned before. And then we have to interpret the results. And the interpretation can be problematic because how do we interpret? We put some subjectivity into the objective findings. And then, of course, we have all these biases along the way. So first of all, should we study? Should we study at all? For example, should we fix a bone fracture? Is this something that we should study? Some things are still obvious, and not everything should be studied. Evidence-based medicine is not really good for rare or complex or specific cases. Evidence-based medicine is based on measurement, but not everything can be measured. Can we measure trust? Can we measure expertise? Can we measure experience? We take subjective data and try to make it objective. We may lose some info in this process. So we have to reduce complex subjective findings into numbers, and we must lose something on the way. What about methodology? We should choose the right study type. We should use statistics, and of course we have biases on the way. So each phase of this part of the methodology is prone to mistakes. First of all, we have to think which study format we have to choose. Randomized controlled trials are considered as the queen of evidence-based medicine, and they are maybe the gold standard, but not everything is fit to be studied by RCTs. They have their own limitations. They are limited in size that we can actually reach, limited in time that we actually follow this patient. They are limited in detecting small differences, and sometimes we lose some factors on the way, for example, skill that can be diluted in big studies. We have to define what we really want to investigate and choose the right method. Do we want to find causality? Do we want to define feasibility? Do we want to find applicability to the wide applicability to all the surgeons around us? So if you use randomized controlled trials, sometimes it's really the best method because it fits to study novel treatment, standardized procedures, stable effect, treatments that are easily tolerated, like drugs. And this is very good, for example, for new drugs. But this is not surgery. In surgery, you are limited by blinding our patients. We are limited in using placebos. We don't have a lot of, we have insufficient standardization, and sometimes training is a limitation. We have a learning curve which changes the results along the way. Sometimes we should avoid randomized controlled trials. Sometimes they are unnecessary, inappropriate, inadequate for our question, or impossible to perform. And sometimes we should use alternative level of evidence. Not everything is best studied by randomized controlled trials. Sometimes we should use real-world data, avoid selection bias, and for that, non-randomized trials, population-based, may be better. Also, it was mentioned here about study quality. We take almost for granted everything that was published, but we know that the publication industry with the open access and pay for publishers is blossoming. There are many, many studies that are getting published, but no real value. Even meta-analysis, which is considered the best, may enhance low-quality data because it can fixate mistakes. For example, in this example, there's underreporting of SSI. Sorry, there's underreporting of SSI in. SSI in 216 trials because each one of them underreported the SSI incidence, and the meta-analysis fixated this mistake. What about statistics? Very few of us really understand statistics, and very few understand the meaning of statistical results. We have to apply the results from group to the individuals that we take care of, and sometimes this application is not really straightforward. When we talk about significance, what is really significant in the eyes of whom? What is the ultimate goal of statistics? It would be great if we could lump all the relevant randomized controlled trials into one giant meta-analysis and come out with a combined odds ratio for all the decision. And for Douglas Adams fans, the number is 42. But this doesn't really work. And it was said that statistics is like a bikini. What it shows you is very interesting, but what it doesn't is far more interesting. And there's no truth in science, just probabilities. Let's talk a little bit about biases. There are many things that consider the biases, and we should know where to look at. And in science, we have to look not at the wife, but at the biases to find the truth, and sometimes follow the money trail. So there are many biases that are very well known, like selection bias, publication bias, was mentioned here, confirmation bias when we do the study to confirm our beliefs, success bias because we look for successful evidence when you ignore the failures, and many others. But there are some biases that are less well known, like follow-up biases. Look, for example, what happened to a group that studied the use of biological mesh for repair of paraesophageal hernia. They are very enthusiastic, and the first publication, evidence-based, was very pro the use of this mesh, but along the years they changed their minds. Series of publications from the same group with added evidence and change of mind. There's also the surgeon skill bias. It's rarely measured or mentioned. It's not very politically correct to say that some surgeons are better than the others, but we know that there's an impact on the income. For example, this study that examined the rate of pancreatic fistula after Whipple operation and showed that the best surgeons had less fistula. So something that we don't mention, but it helped. It's really important. Or the bias of outcome definition. How how do we define what we want to measure? Because it all starts by what we want to measure. If we define something different, we can find different results. It's easier to analyze something that is quantitative, and we have yes or no questions. It's very easy to analyze, but not every question is a dichotomy. For example, if we go back to the mammography screening, if we look at the benefit, if the question was how much life do we save and the benefit in mortality, then it's very low. But if the question is different, for example, if we ask how many patients do we identify at an earlier stage, in how many can we save a mastectomy and do only lumpectomy, in how many can we diagnose early and eventually avoid chemotherapy, then the answer may be completely different. So we cannot really dismiss screening mammography just based on one single question. Maybe there are many questions to be asked. External pressure, payers, public opinion, fashion, industry, these are all biases of third parties. And it was mentioned already, the influence of the industry on our study. Some studies have low chance to be performed at all because there's no profit in them, and you cannot get the support to do them. It doesn't mean that the questions are not important. Another problem is when we come to the interpretation of our results. Like in court, we know we can compare ourselves to the police. We want to collect the evidence, but someone has to make the sentence. We already heard about judges this morning, and how we interpret may change according to our mood or our beliefs or preconceptions. We can mix association with effect. We can forget about the magnitude of the effect, mention the effect, but it's not really important because the magnitude or the effect on our practice is really minimal. We can mix clinical significance with statistical significance. We can mix relative and absolute change. And what is really important is really dependent on what are the parameters that we define as important. There are some numbers that we sometimes don't really look at, and they are important in our interpretation, like the number needed to treat, number needed to harm. Not every study that shows benefit actually measures the harm that being caused by the same intervention. Maybe there are alternative explanations. Can we generalize the conclusions to other surgeons, to other patients? These are all issues that has to be considered. The applicability of our conclusions also, not every time the applicability is not really easy to use, because sometimes the study surgeon is not similar to the common surgeon out there that reads the study. For example, if you look at lap inguinal hernia, many studies support that this is there are advantages over open hernia, but still it's not really widespread because those who make the study are not those who actually perform the operations. There are some effects of evidence-based medicine that can be seen as negative effect. They promote dichotomic decision. We ask what's better, but not every time we have to ask this question. Many times we can have similar solutions that are equally good. It limits the variability, limits the options, It promotes rule and guidelines and standardization, which may be a good thing, especially medical legal-wise, but it may limit improvisation, innovation, and diversity. So if we paraphrase Churchill's famous saying about democracy, democracy is the worst form, but this is it's the best of what we have, we can say that evidence-based medicine is the worst way for advancing surgery, except for all those other forms that have been tried. But we have to know how to use it. We have to be aware of the limitations, know when it's applicable, use the correct methods, identify the faults, and keep the skepticism. Thank you very much.
I think that we really have to look at the clinical relevance of studies as compared to statistical relevance. And the best examples are studies of 15,000 patients, it's very statistically significant, who showed a benefit of 4 weeks in some malignancy with drug A versus drug B. So it costs a lot of money, it's statistically significant, but it means nothing. So I think, as Danny and Ahmed said, we have to be critical and look how many patients did it take to do this study, how many years. A study that took 20 years to recruit maybe is not good, and is it really worthwhile?
Thank you. You know, this morning we heard so many wonderful presentations about evidence-based and decision-making in surgery, and I think at the end of the day, you know, the evidence should help us make the right decision in our patients preoperatively, intraoperatively, and postoperatively. So we're going to give surgical answers to my question. We're going to go fast, so don't give me a long presentation. But why don't we start with Dr. Keyser? How often does the evidence help you, evidence versus experience, to make a preoperative decision on your patient? Do you use more your experience or the evidence? Preoperative.
If there is only one publication that must change my strategy, in most of the cases I don't use it.
You use your experience?
Yes.
Dr. Menes, Professor Menes.
Not quite.
Oh, well.
In breast cancer surgery, we use it all the time. I think it's one of the fields that is most advanced in evidence-based data, dating back to the NSABP studies that were led by surgeons. So most of the decision-making that we do, if it's regarding the surgery or the entire treatment, is evidence-based.
Petachia, your indication for surgery preoperatively, is it evidence-based or experience-based?
Well, I think it's both, but I think that we have to be flexible enough to change our habits or what we learned from our mentors in face of new evidence. I don't think we should rush and change our practice, but we should be aware with all the limitations that were beautifully shown by Dr. Danny Rosine. But I think the beauty of our profession is that we have to be flexible.
Thank you. Yoram?
I agree with Petachia. We use the NCCN guidelines on a daily basis. And this is evidence-based medicine. And part of it is our experience. So evidence-based medicine is part of our life on a daily basis.
I hear that experience seems to be more important than evidence. Mitch, how is it in Chicago? Cold in the winter.
We vote twice for everything, so it's much easier. I think obviously nothing can replace experience as a platform, but I think that we are fooling ourselves if we don't think that evidence should guide us, and I think the example of breast cancer is exactly correct, because when we talk about breast cancer and the management of breast cancer patients, we have substantial evidence that is high quality, that is able to guide us for almost every decision we make at this point. On the other hand, in the areas that I practice, which for one example is pancreatic cancer, we have very little evidence to guide us in terms of what we do. And I think surgeons are at fault, quite frankly. I think that we depend on each other to be able to make valid decisions about what to do. And I think that, you know, in an example of pancreatic cancer, which is really the most lethal cancer we have, nobody should accept anything as standard of care at this point because the standard of care is horrific. You just have to look at the incidence of mortality, and if you accept that and say that what you're doing is correct is just, to me, fooling yourselves. So I think we have to push surgeons to act in a way that takes advantage of their intelligence, their experience, and to design trials to answer questions. And I think without doing that, we're doing a disservice to our patients.
Now, at the end of the day, the reason we are emphasizing to work evidence-based is because our patients should be doing better, correct? What we're trying to do is improve our outcomes and our relatives and ourselves go in and out of an operating room with a better outcome. How is it in the operating room? Do you really use evidence? Why don't we start now from left to right? Do you really use evidence or experience to make your decisions in the OR? Where is the evidence there? Let's go, Mitch.
I'll be brief. I think that the fact is that in the operating room, I think there's unfortunately, very little to guide us sometimes in terms of the conduct of our operation. I'll also offer, and I think this is important, when you look at randomized clinical trials in cancer, very often the only modality that is not controlled is the conduct of an operation and what you do and the standard. And that unfortunately provides evidence that may not be great evidence in terms of making your decisions.
Yoram, how important is the evidence versus your experience, your hands, your skills in the OR?
I think that during surgery, practice and experience is much more important.
I agree. Pitahia?
Yeah, I also agree. I think we all have the same goal, and each one of us may have different ways to reach that goal. And I think you have to really adopt whatever works out better for you for the sake of your patient.
Dr. Menes?
I'll go back to the example of breast surgery, and I'll say the opposite of what I said before. I think in the operating room we tend to adopt techniques that are not yet evidence-based, like if lumpectomy was done long before it was proved to be the same as mastectomy. We've sort of abandoned axillary dissection even for patients that we know have a positive lymph node and have gone through neoadjuvant. Although we know sentinel node biopsy isn't accurate, it is, I think, a combination of what the patients demand and what we feel is right, and not always evidence-based.
Dr. Keyser, experience or evidence in the OR?
I'm using both of the tools, my experience, and I never ignore the evidence-based medicine.
Well, we heard from Dr. Asalia. We have a hand. First, we're going to get the audience. Dr. Begleiter.
We talked this morning about decision-making under uncertainty. We didn't define uncertainty. And people may think that uncertainty comes when you lack data. You lack data, you don't have the data, so you're under uncertainty. I have another problem. You are in uncertainty even if you have a lot of data. This is my problem, and I don't know how to solve it. I mean, you have conflicting data, and in order to resolve conflicting data from RCTs, you have meta-analysis, but you have conflicting meta-analysis. You have too much data, you have all the data, and you stay in uncertainty.
Professor Klausner.
It's very evident that there are many limitations. There are many advantages against heuristic, but there's one aspect that lacks completely evidence. And this is the application of new technology in the operating room. Completely no evidence. Everyone who wants to invent an operation can do it without any rules. You want to do an operation laparoscopically or robotically, or use a new technique or something. It's completely open. It takes some 5-7 years to, investigate these indications for a new indication. But for surgery, every surgery is evidence of result.
And you make a very, very good point, because for drugs and medications and devices in America, we have the FDA. But when we want to change an operation, as Dr. Rosine mentioned, a Bill 2 to Roux Y, there is no FDA. The surgeon can choose. The patient has to believe. So why don't we go from right to left? How about robotic surgery? Do you think that there is any evidence in the literature that justifies for us to be doing robotic surgery on our patients? Yes or no? Dr. Keyser?
Not in general surgery.
Dr. Menes?
I'm still wondering about breast surgery.
Dr. Reisman?
I don't think there is any evidence of any advantage of robotic surgery. I think it's mainly industrial driven and influence. I mean, I appreciate them convincing us to have something that we don't need, but I think this is the fact.
Professor Kluger?
Very costly, no.
Mitch?
Whether we're willing to accept it or not, it is going to be the future. I think that...
Why you say that?
I will tell you if you give me a second.
I want to hear that. I'm intrigued.
And I think it's a matter of changing perception about a technique. It doesn't make a difference to me how you take out, you have to use cancer obviously, as long as you're good at it and do it well. There are certainly surgeons who use robotic techniques that are superb at doing a Whipple procedure, for example. And their results are exactly the same as mine, and they may even be better once we get the experience. I think you may know that there have been significant assessments of robotic surgery for a Whipple procedure. And what it shows is that the mortality from a robotic Whipple is double that of an open Whipple. But the question is, why is that? And it's very clear why it is, that when you separate out high-volume centers from low-volume centers, in high-volume centers, it's exactly the same as open procedures. In low-volume centers, it's at least double the mortality, and it means that it's being adopted by individuals who don't have the same experience as they have open. And my guess is that's the case in everything we do. Now, the question is, are we willing to accept a learning curve that for a Whipple procedure is quite extreme? So we know you pretty much have to do 80 to 100 Whipples in a robotically to become experienced to be able to reduce your mortality. Now, I may accept that scientifically. I don't know that anybody tells the patient that their chance of dying is double what you do open. That being said, it's hard for me to believe that that technology over time will not improve dramatically. The experience of our young surgeons who are now very adept both laparoscopically and robotically, I think will exceed what we can do open at some point. So I think that the writing's on the wall. I don't think robotic surgery is going away. I really don't. I can't do it, and I will never learn to do it in my lifetime, but that doesn't mean that I'm not willing to accept that there are others who can do it as well, and hopefully with time show improved outcomes with it.
Now, Dr. Asadia said in his presentation towards the end that why shouldn't we introduce technology like we did with Lab Chole? In 2 years, standard of care. Do you think that the way we did Lab Chole, because it went well, we should be doing it the same way with robotic, with single incision, or other technologies? Yoram? Take the microphone. Yeah.
We did it. I mean, robotic went into our practice like it's the same like lab cholecystectomy. Nobody proved in prospective randomized studies that robotic surgery is better than laparoscopic. We are starting to get these papers out now. But in the beginning, this was introduced into our operating theater without any evidence, just because of the industry.
Petachia, you think we did right with Lab Chole?
I think, looking back at history, we definitely did the right thing. But I want to address what Mitch said. I think it's not fair to compare robotic surgery to open surgery. I think if you want to compare, you have to compare robotic surgery to laparoscopic surgery. And I think the way things are being promoted, you know, people talk about robotic versus open, but I don't think this is the right comparison. I think you need to compare the robotic towards laparoscopic. And of that, I'm not aware of any randomized controlled study that shows that robotics are really more advantageous.
And I think you're correct, but I do also think in these very complex procedures, those individuals who are exposed to robotic actually think it's an easier procedure to learn robotically than it is the skill set that you need laparoscopically. And again, I don't think we have the answers at this point, but as I said, I don't think the technology is going to disappear. I think it will be improved. Hopefully at some point there will be some competition and not just one company selling their robots to everyone. But you know, the same is true in robotics when you look at prostatectomy. I mean, who would not have their prostate removed here robotically? I think almost everyone would choose that avenue. And there are not randomized trials that prove necessarily that it's better. But when you look at a large anecdotal experience, it certainly appears that way.
Well, I think with that, the point is that industry was able to jump over laparoscopy because you won't find in the literature comparison robotic versus laparoscopic prostatectomy. And the reason why is because the urologists, with all due respect, don't have the skills. So the robot is an expensive needle holder, in my opinion. Now, let me ask you another question to the whole panelists. In America, at least, the American Board of Surgery mandates that if you're training residents, you need to put them through simulation. But we hear today from Dr. Rosine and Dr. Asalia and from many other speakers this morning that the highest level of evidence, we get it from the RCTs, the systematic reviews, and experience. But we still don't mandate in America that when someone goes to surgery, needs to have an experienced surgeon. I mean, when you get on a plane, it's part of the TSA. You've got to have a white hair or bald pilot with a young one. When you go to the operating room in America, I see sometimes two youngsters go into the OR and do a case. Don't you think that we should be mandating in every single case, more important than having simulation and having RCTs, that there is always an experienced and a junior surgeon there? Why don't we start with Dr. Keyser? What do you think?
I think that you need an experience. Experience is very important. And, you can send a young surgeon to operate, but they must know that they can call you and you can assist them.
Dr. Menes, if you have this big breast tumor infiltrating the axilla and your junior partner wants to do it, do you say, hey, you can't do it without me being there? Do you do that? Or you let them go and do the case?
We give them neoadjuvant.
Petachia, what about this patient that has an atrophic right kidney, has a bad sigmoid diverticulitis, and one of your just newly graduated attendings wants to do the left hemicolectomy with a robot? Do you let them do it, or you say, I'm going to be there watching you?
Yeah, I think this is our obligation to our patients, to use our judgment of who can do what, and if there is a real good indication for the plan of the specific surgeon, and I will definitely have to, be involved in the case that you just described, and I think this is our obligation.
Because it's not only what the literature says, the RCT and the systematic review, is what the experience also tells that
Absolutely.
You're going to get the best outcome for your patients.
Absolutely.
That's the best evidence.
I also don't think that you can get a simulator simulating such a condition as you just described. So it's not going to help.
Yoram?
I assume my attending surgeon have a common sense to do the case by themselves. They don't need me in the operating theater. But in regard to resident, I think that the resident should be guided through his residency, and this practice in the operating room is not going to be changed with simulators. So he needs to be in the operating theater, as we did, day and night, in order to get practice.
So you're telling me that your 20 years more experience in the operating room is not going to be valid for the outcome of that patient because the other surgeon just graduated 2 years ago and he has the certificate from the good saying you're a surgeon. You don't think you should be there?
No, I think that the technical part of surgery is very, very much practiced by our attendings and young residents. But I think that my input is before surgery, not during surgery. I think that the discussion, the team approach to the patient is much more important than my involvement during surgery, although I'll be called for the complicated cases in sometimes, but not necessarily every time.
Mitch, you got a problem, because in America you cannot get into the OR of your attendings. They kick you out, no?
You know, I think the points here are all incredibly well taken, and I think, you know, a surgeon is not just the technical skill that you apply in the OR, and I will offer, I can teach anybody how to operate. It's very hard to teach judgment, and I think that does come from both experience. I think it comes from assessing a situation from many vantage points and not just taking for granted what you do. And I think it comes from somebody really taking account of both their strengths and their weaknesses. And nothing supplants judgment and competence. And I think we could argue here, well, how do we measure those things? And we don't do it very well. None of us, I mean, how often as a chair, Professor Klausner, have you watched your faculty operate and assess them? And the answer is we don't. Very often we have no idea what they're doing in an operating room. We know what the outcomes are, and we can figure it out at a morbidity and mortality conference. But I think it's a very, very complicated issue, and I think that it's something as surgeons we don't address very well.
But I must say something, Mitch. In socialized healthcare systems like in Israel, like in Europe, the reputation is from Dr. Klausner's department and hospital if things go wrong. While in the United States, it's not you, it's Dr. X or Dr. G that happen to be affiliated with the University of Chicago, but it's their problem. It's not your reputation that goes down. So what I'm trying to say is that the socialized healthcare system pushes us much more to do evidence-based surgery, meaning not only RCT and data, but also to have the experienced guy in the OR when making a decision pre- and intraoperatively than we are in the United States. Although we are writing all these things now. But last comment, Mori. So in the interest of time, it's an hour. Let's give them a big round of applause. Thank you very much.